Our first presenter is going to be Dr. Carlos Del Rio, who is the Hubert Professor and Chair of the Hubert Department of Global Health for the Rollins School of Public Health and Director of the Clinical Science and International Research here at Emory, as well as the Director of the Emory AIDS Training and Research Institute. Dr. Ihab Hajjar, who's the Clinical Trials Director, who's a geriatric physician and Director of the Clinical Trials Unit here at the Goizueta Alzheimer's Disease Research Center. Dr. James Law, who is Director of the Neurocognitive Behavioral Unit here at the Goizueta Alzheimer's Disease Research Center and Director of the Clinical Research Unit, as well as Director of our Emory Healthy Brain and Aging Study. And our final presenter is going to be Dr. Laurence Sperling, Director of Preventive Cardiology at Emory University School of Medicine, and founder and director of the Preventive Cardiology program at Emory, and also a part of the Rollins School of Public Health. So gentlemen, thank you so much for joining us. We hope to get started. I'm going to start because I know Dr. Del Rio has to get on rounds. Dr. Del Rio, would you mind going on so you can get back to your rounds? Dr. Del Rio is going to give us an overview and an update of COVID-19 and where we stand with the virus, its diagnosis and evaluation at this point in time. Dr. Del Rio.
So thank you very much, Dr. Parker, and happy to be with you. I think that we are really in, I think this word has been said too many times, but it's true. We're really on unprecedented times right now with the epidemic of COVID-19. This is a disease that, we didn't even know existed in late December, early January, and we're over 9 million cases globally, and we're approaching 500,000 deaths globally. We have here in the United States close to 2.5 million cases and over 120,000 deaths. And one of the things that we have seen in our country is a couple of things that are important to notice. Number one, while 60% of the cases have been in people under 65, 60% of the deaths have been in people over the age of 65. So obviously a disproportionate impact on morbidity and mortality among people over the age of 65. And what that means is that this disease can cause, this infection can cause all the way from asymptomatic to very minimally symptomatic disease, which is usually what you see in young people, to very severe disease, which is what you see more in older people or in people that have obesity, diabetes, hypertension. Number two, we're seeing also a very, we've always suffered in this country from health disparities. And I think this disease is really a disease of health disparities in which we're seeing a disproportionate impact among among African Americans and Hispanics and among the poor. And then the one thing that we're also seeing is that we know more and more about the transmission. We know more and more about what to do to prevent transmission. And I think that we have sort of given up on the ability to do that. And I would emphasize that even though we still don't have, and we won't have for many months, a vaccine, clinical trials are starting soon. Probably in July, we'll be starting clinical trials, phase 3 of a vaccine, and many other trials are happening around therapy. So we are in a very critical point. I think that we really need to take this epidemic seriously. I think we need to take precautions. We need to, the world has changed as a result of this. And the one thing I don't want to do is I don't want to see you come to the hospital. I really don't want to see you in the emergency room. I don't want to see you in our ICU beds. And I really don't want to see you die as a result of this disease. So please take care, wear a mask, social distance, and wash your hands. Thank you.
Thank you, Dr. Del Rio. There are a couple of questions in the chat, if you don't mind. One question that we had was, how do I return to work if my employer does not require a face mask?
Well, that's a good question. I think that you need to tell your, I don't know who your employer is, but I think we need to really tell our employers that they need to follow CDC recommendations. And I would ask who your employer is. And I would really make a point that, you know, what I want as an employer is I want healthy employees. And I think in order to have healthy employees, I would like to see people wearing a face mask.
Excellent. And you mentioned the vaccine. How you said maybe July it will be in the third phase. How close are we to getting a vaccine?
Well, we're far. I mean, as I said, in July we will be starting phase 3 clinical trials, but it's still in clinical trials, right? We need clinical trials to occur, and it's going to take time. However, I would say that the government is really putting a lot of effort in. I mean, we're starting clinical trials, and at the same time that we're starting clinical trials, we're also starting production of the vaccine, which means we're not waiting for clinical trials to finish in order to use the vaccine. We're starting production, so if the clinical trials show that it's useful, we already have the vaccine. And if the clinical trials go well, we should have a vaccine by the end of December, early January, which will be tremendous. I mean, we've never seen a vaccine develop so quickly.
And are we in the first or the second wave of the virus?
Who knows in which way we are? You know, it never went away. So the reality is we're in a consistent phase of the virus.
Got it. And then 2 more questions. How much of the disparity in the disease burden do you attribute to the difference in our communities when it comes to access to coronavirus testing?
I think it could be that, but I really think that the major disparities we see is that the people that you are seeing severely affected are either frontline workers. You know, if you're a grocery employee, if you are a service employee, or you are somebody who works in housekeeping, you're not able to telework, right? You have to come to work. You have to come to work. You get exposed. You have to take public transportation. And number 2, you live in fairly crowded conditions. And I think those are the things that are putting at high risk and making it the disease more severe in minority populations.
Okay, and 2 more questions and we will let you go. What is the current treatment for older adults who are hospitalized with COVID?
So we've seen a lot of advances in treatment. At this stage of the game, in people who are hospitalized, we are sort of routinely, if they need oxygen or if they're critically ill, we routinely are starting them on remdesivir, which is a new antiviral that has offered some benefit. It's probably the only drug that has really shown some significant benefit. And then most recently, as a result of a study that yet has not been published, but we have some data, we're also using dexamethasone. I think those 2 drugs, remdesivir and dexamethasone, are really what I see as a standard of care right now. But clinical trials are happening to develop drugs that we can take by mouth. Okay,
and is the virus mutating?
You know, every virus mutates. And to me, that means, viruses mutate on a regular basis. Do people mean, sometimes mutations make a virus less aggressive, sometimes it make it more aggressive. So I'm not sure what exactly that meaning is.
Okay, and then last question, I promise. So who should be tested? If I have symptoms or don't have symptoms, should I be tested?
I think everybody should be tested. If you have concerns, if you've been exposed, I think you should be tested. And testing certainly if you have symptoms, you ought to be tested. But if you've been exposed to somebody, if somebody in your work has the disease, you need to be tested. I think it's important that the more we test, testing allows you to know whether you're infected or not, allows you to protect yourself, but more importantly, allows you to protect your family.
All right, okay. And I still see the questions coming in, but we have 4 more presenters, so thank you so much.
Thank you so much. I'll talk to you later.
Thank you. Okay, let's transition over to Dr. Monica Parker. She's going to be giving us an update on brain health. So Dr. Parker, if you want to introduce your topic while I pull up your slides.
Sure. One of the reasons that we are conducting this outreach is to make you aware of exactly what we do here at the Goizueta Alzheimer's Disease Research Center. Part of what we do is give you information that you can use to make a choice, an informed choice, about participating in neurocognitive research. That means research into Alzheimer's, research into anything that can go wrong with the neurologic system and the brain, such that you are no longer able to take care of yourself. So we start with, it says Goizueta Alzheimer's Disease Research Center. But Alzheimer's disease is part of a spectrum of disorders that we call neurocognitive disorders. So exactly what is dementia? Well, it is there's a definition here. It's coming up in just a second. But the important thing about what dementia is regardless of what causes it, the person is no longer able to conduct any of his or her usual daily activities like feeding, grooming, dressing, maybe not even do your own job. It is not a normal part of aging. You know, decades ago, we used to think that as people got older, they invariably lost their abilities to think and to process information. But in its strictest terms, dementia is defined as the loss of 2 or more brain functions we call cognitive domains. These include things like executive function, memory, language impairment, judgment, problem solving, visual spatial interpretation, and praxis, which is kind of like moving your hands and things around, physical mobility. So what are some of these things? When people think of Alzheimer's, they only think in terms of memory loss. Remember, that is just one of at least 6 domains that we look at. What is executive function? Next slide, please. Okay. Complex attention. These are the domains that we're talking about. Complex attention, that's the ability to attend to and process information, like listening to us on this webinar, looking at our screens, interpreting what you're looking at and hearing. Executive function, the ability to plan, to organize, to complete tasks and projects. Learning and memory, which is fairly self-explanatory, but by definition, remembering items, facts, words, their meanings, events, people, procedures, skills, remembering things like how to drive or how to get from your house to the post office. Those are learned things that you can forget when you develop dementia. Perceptual motor, manipulating things, motor tasks, picking things up, moving them from point A to point B. Language, expressive and receptive language skills, using the right word for the right object, communicating appropriately. And social cognition, using socially appropriate behaviors and using proper decision-making skills and exhibiting empathy. So these are 6 different domains, and when you have deficits in 2 or more, we say that you have a definition of dementia. So what are the different types of dementia? Next slide, please. This is our pie chart that kind of like graphically depicts the different types of dementia. Now, regardless of the dementia, you can have deficits in those domains that we just finished talking about. Most commonly diagnosed dementia is Alzheimer's, followed by a mixed dementia, which can be Alzheimer's and vascular disease, Alzheimer's and Lewy body disease, vascular dementia, Parkinson's disease, frontotemporal dementia, chronic traumatic encephalopathy, and chronic alcoholism. Those are all neurocognitive disorders on the spectrum of dementia. So again, look at this pie chart. There are several different types of dementia that all have the same, result in the same problems. The individual is no longer able to take care of his or her affairs. Next slide, please. What are some, these are the different types of dementia and their prevalence in society. There are 2 here that are not likely to affect you after the age of 65, but are of concern because they can affect you well before you become geriatric. Particularly vascular, which Dr. Hajjar and Dr. Sperling are going to talk about a little bit later. Early onset Alzheimer's is Alzheimer's that begins before the age of 60. Frontotemporal begins between the ages of 50 and 60. And then Lewy body and mixed. They can occur at different times, but it's important for you to note that people can suffer from dementia at any age, okay? You do not have to be geriatric or over the age of 65 to get dementia. How do we treat them? You can see what we use to treat them, but for the most part, none of the medications that we currently have available are what we call disease interferers. They're not disrupting disease, they're not fixing the disease, they're not curing Alzheimer's. We don't yet have a cure. We're getting close to it, but we don't have one now. Next, please. What are some of your risk factors for neurodegenerative or neurocognitive disorders? Well, there are things that you can do something about, and there are things that you can't do anything about. Most common risk factor for developing a neurocognitive disorder is age, getting old enough, your gender, being female more so than male, genetics. We have a number of different genes that are associated with Alzheimer's, ApoE4, ABCA7, but there are a whole bunch of other genes that are associated with dementia that have not been as widely studied. Research is still ongoing to figure out what some of these things are. Some of the other things that put you at risk for developing dementia that are more common: vitamin B, D, niacin deficiencies, poorly managed diabetes, chronic diseases like type 2 diabetes, high blood pressure or hypertension, chronic anemia, chronic kidney disease, coronary artery disease, chronic lung disease, and different kinds of cancer. And finally, arrhythmias, irregular heartbeats, cardiovascular disease. What are some of the environmental risk factors for neurocognitive disorders? Delirium, which is fixable depending upon what's causing the delirium. Taking medications that are interacting badly with one another. Maybe you take too much, maybe you take too little. People who suffer from head trauma, chronic head trauma, not just athletes, but people who are victims of domestic abuse. Chronic smoking, which leads to vascular risk factors for vascular disease. Brain irradiation, as with chemotherapy or therapies for brain cancer. And chronic alcoholism. So there are things you can't fix. You don't fix your age, you don't fix your gender, you don't fix your genetics, but you do fix the things that have to do with your lifestyle. You can make a choice about smoking. You can make a choice about alcohol consumption. You can make a choice about a better lifestyle to improve upon your risk factors for hypertension and adult onset diabetes or type 2 diabetes. Next. How do you diagnose dementia? Well, you have to do a number of different things to get a diagnosis of dementia. It starts with your annual wellness visit and your screening visit in your doctor's office. You get screened for depression and you get screened for dementia. Screening doesn't mean diagnosis. It just means that we need to do a little bit more testing. Okay, that's a 5 to 10 minute test in the doctor's office. And if those things are abnormal, the doctor will order other things. A comprehensive examination for a dementing disorder will require that you have a comprehensive medical history, a review of your medications, and a physical exam to make sure that the symptoms that we're seeing are not caused by something physical. Okay, the other thing that's a part of the evaluation or diagnosis is a brain image. Most commonly, that's going to be an MRI of your brain. In some centers, you may have access to a PET scan, a special kind of PET scan that looks for Alzheimer's pathology. And then there are laboratories that you have to look at to make sure that things are okay. That includes thyroid function, a metabolic profile, a check for diabetes being in control, check for anemia, a check for syphilis, and looking for things like vitamin D deficiencies, vitamin B deficiencies, and folate deficiencies. And finally, a pen and paper testing to see how your brain is actually processing information. I call this the IQ test for geriatric patients. It's like learning tests, like skills, but it's something that you do when you get a little older, and we try to see what your brain is able to do and what you're not able to do. And with that, I think I've tried to give you a broader understanding of what dementia is, more specifically what it is not, and most importantly, that there are different types of dementia that require a series of different examinations and tests in order to rule out and to rule in certain diagnoses. In any event, at this time, I'd like Dr. Law to come on and talk about the different research we're doing, particularly as it relates to healthy aging. Thank you. Dr. Law?
Thank you, and thank you all for joining us again. And Cornelia and Dr. Parker failed to tell me what I was supposed to talk about today, but I think I can do that off the top of my head. There are a number of really important research initiatives. Some are very specific to treatment approaches, so there are clinical trials for some of our patients. But what Dr. Parker alluded to was studies related to healthy aging, and this is where we ultimately need to go. Just like with COVID-19 and the vaccine, we expect to make advances in our ability to not only treat the symptoms related to Alzheimer's and related diseases that cause dementia, we also expect to be able to prevent the disease, which is ultimately how we're going to defeat these conditions. And the way that we're doing that is by understanding that, that these are chronic conditions. So if we just think about Alzheimer's disease, Alzheimer's disease doesn't start when you start getting lost or repeating yourself or forgetting things. Alzheimer's disease as a pathology, as a biological condition, is happening in your brain for up to 20 years before those symptoms of memory loss start. And not only that, we've developed the technologies over the past couple of decades that we're able to determine the presence of the pathology in a healthy individual's brain. What we cannot yet do, though, because if I take a step back for a second, when we do autopsy series on healthy individuals who've died in their 70s or 80s, many of them, people who are in their late 80s, the majority of these healthy people who had no memory problems actually show signs and evidence of Alzheimer's pathology in their brains when they died. So the point of that being that many of us may die with a brain full of Alzheimer's pathology, but never be sick with it. And so if we're not going to be sick with it, we don't need to be treated for it. The problem is that when we detect the pathology, we can't currently predict who's going to get sick or when they're going to get sick. And so that's been the thrust of a lot of the research that's been happening in the Alzheimer's Disease Research Center. That's the entire purpose of the Emory Healthy Brain Study, is to study middle-aged people. Middle age used to be my age plus 10, but we've arbitrarily now defined it as being between 50 and 75. And enrolling cognitively normal individuals between 50 and 75 who are willing to participate in fairly extensive studies, including lumbar puncture, and over 1,200 individuals have already done this. But we want to build that number to 3,000 or more so that we have sufficient numbers of individuals to discover these tests that will allow us to predict who's going to get sick, who would be appropriate to enroll into a clinical trial for prevention, and ultimately determine who needs to be treated with these drugs that are developed as we go forward. And so that's where we're headed. These sessions focus specifically on men and also targeting African-American men. We've done that very consciously because about 2/3 of our research participants in both the ADRC and in the Healthy Brain Study are women, and the proportion of Black men versus Black women is even worse than that. I think it's more like 80-20 among our African-American participants in that study. So we'll be making concerted efforts to even out the distribution so that as we discover these things that allow us to both determine the presence of disease and predict the likelihood of progression and sickness from disease, those results will be applicable across men, women, African Americans, Caucasians, Asians, Hispanics, and every group under the sun. So I think that's all I'm going to say on this, and hand it back over to Cornelia.
Okay, one question before we close, Dr. Law. Can you talk really briefly about the spinal tap?
Oh, sure. I don't know if that was a question from one of our participants or from you. The spinal tap is something that tends to provoke the most anxiety. And it's really, it sounds awful. Somebody should come up with a different name for it, whether we call it a spinal tap or a lumbar puncture. It just doesn't sound very friendly. As a general rule, it's extremely safe and relatively painless. The only people we worry about are individuals who have a bleeding risk for whatever reason, or if they're on a blood thinner, not aspirin or Plavix, but actual blood thinner like warfarin or Eliquis. We won't do the procedures in those individuals because of a heightened bleeding risk. But the procedure on the website for the Healthy Brain Study, there's a video. I don't think you can ever actually see my face on it, but the butt that's in the side of the video with fluid being drained out of the back is me having my second spinal tap, and I'm actually signed up for the Healthy Brain Study. So I'll be getting a spinal tap every couple years. And the first time I did it just because I wanted to make sure it didn't hurt. It's just a little tiny needle. The worst pain is the numbing medicine. And the needle is so thin, you won't even believe it. It's basically the thickness of a standard fishing line. And the procedure is simple. It's fairly painless, and I don't know, and other concerns related to that. We explain everything pretty thoroughly, and so it's normal for it to be a little anxiety provoking, but 90+% of our participants who've gone through that have said that it's either no worse or much easier than what they were anticipating.
Perfect. All right. Well, thank you for joining us. Next up, we are going to have Dr. Ihab Hajjar. He is the assistant professor in neurology, stress, and the brain. So Dr. Hajjar, I am going to hand over the remote control to you, and you can advance your slides.
All right. Well, thank you. Appreciate you all joining us today. I was asked to talk about stress and the brain, and kind of a timely topic considering all the stressors we are being exposed to day in, day out over the last few months. So I'm going to try to give you a little bit of a overview of what stress can affect in terms of our brain function and brain structure, and also provide some comments about how to counter the effect of stress, which is definitely very necessary and needed these days. So I have a few slides to share, so let me see if I can do that. Let's see. All right. Can you guys see my screen?
Yes.
Okay, great.
If you want to put it in, yeah, perfect.
Is that good? All right, wonderful. All right, so I kind of thought when I was preparing these slides about what are key stressors that we are exposed to, especially in the last year or so. But definitely these are not. It's not an exhaustive list. There are much more or many more stressors that we deal with on a day-to-day basis. For example, if you live in Atlanta, in the old days when we were actually going out and driving, it was traffic. Nowadays, it's less so. So there are a lot of stressors that affect us, and these can be financial stressors. Can we make our payments on our house? Can we pay for the credit card bill, etc. Job stressors. There's definitely a lot of jobs. Almost all jobs have some level of stress. If you are a caregiver, if you have a child or an adult with a disease, that can cause a lot of stress. The continued news about the coronavirus has definitely elevated the stress, and studies have shown that the level of stress in the population have almost doubled. And then on top of all of that, we have the continued and persistent stress that we have from the exposure to injustice and indiscrimination, especially if belonging to minority populations. Before, recently, it was a kind of continued process of being on the news and has exacerbated also recently. So all of these repeated exposures to stressors are what we call microaggression, leading to a chronic state of stress and eventually problems in our health. And it's been known now that stress, especially chronic stress, that is when you are exposed to stress at multiple times, especially and recurrently, it will cause health problems. And people have documented that a while ago, that chronic exposure to stress may elevate the blood pressure. It also causes some other changes that lead us to make some poor judgment or poor decisions, such as stress eating and leading to an increase in weight. It also affects our attention and eventually leading to memory decline. And when you compare people who have high level of stress exposure to low level of stress exposure, both at the cellular level and at the phenotypical level, that is at the structural level, there is an accelerated process of aging. Now at the brain, there is the so-called stress-brain loop, which is a loop in the sense that when you are exposed to stress, the first response in the brain is to activate a system that causes us to produce more cortisol. This increase in cortisol causes itself problems. It causes central obesity, that is, it makes us gain weight and retain fat around the midsection. It also causes some changes in the nerve cells in the brain, and it causes further production of cortisol, and then you get into this vicious loop of chronic stress exposure, more cortisol, more brain dysfunction, and eventually cause to some of these problems that you see on the left side of the slide, which is decrease in attention, short-term memory, perception, difficulties with learning and word finding. And also, to exacerbate things further, stress itself can affect sleep, poor nutrition, and anxiety, and cause anxiety and other emotional distress. And all of these work together, unfortunately, against our brain to function properly. And there's been many studies to document that when you have exposure to stress, there are certain changes in the brain that occurs. So in this slide, what you can see is a kind of a diagrammatic representation of a brain scan. And this is called, this is in the, excuse me, it's a measure of connections. And the brain is made of various connections. So they are connected together through networks. And you can measure the amount of networks or the number of networks in using a brain scan. And there have been comparisons between a person who is stressed and a person who is not stressed. And you can see in the non-stressed person, they have very nice control over all the brain networks. The frontal cortex here is the brain part that controls a lot of our behaviors. And it has a good control when you're not stressed over other factors or other structures in the brain. What happens when we're stressed is this kind of network goes wrong, and therefore we lose our strength to control some of these things. For example, if you've ever had to deal with a deadline, you notice that when you're closer to the deadline, your ability to focus and concentrate tends to decrease, as opposed when you are more rested and have enough time to finish something, then you're more able to control a lot of these thoughts. All right, so with that said, stress exposure is not something we can control, because we are going to be living in our lives and dealing with other things, dealing with other people, dealing with our society, our government, our state, our friends, our neighbors, our bosses. All of this you cannot avoid. So what we can control is how we act with stress. And there are many ways where we can minimize or decrease the effect of stress on our health. And some of them are really simple. For example, if one feels that certain thing stresses them, then when they are ready to be exposed or exposed to it, a simple thing as deep breathing, which is take a deep breath and exhale and inhale, that activates the nervous system to kind of tell it to relax, and causes eventually decrease in the stress response. Other ways to minimize effect of stress is to do imagery therapy. And imagery therapy is something that people have used in a lot of instances. And that is to imagine yourself in a quote unquote happy place, and try to imagine yourself being in that state or in that location. And that also decreases the stress response and helps the brain to release less of that cortisol that causes us to be very stressed. Spirituality and prayers is a way that a lot of people depend on to relieve the stress that they encounter in their day-to-day life. Exercise and sports involvement is definitely a very important and very commonly used way to manage stress. If you exercise, you can probably notice that the difference in your state of mind before you exercise and after you exercise, how things are different in terms of your ability to handle some of these stressors around you. Having a social network, which unfortunately has been disrupted with the quarantine, but definitely there's been many studies to support this idea that the more people you interact with in terms of a positive interaction, obviously, the better you are to deal with stress. And then finally, the last point, which is probably one of the more important points to dealing with stress, is to recognize that you are stressed and then know what's stressing you. So keeping a diary, mental diary, I guess, of what is stressing you is important. So if there are situations where are avoidable and are stressful, then you can try to manage your way around these. So, and this belongs to this kind of idea of mindfulness, which is one way to handle stress, is to be aware of what, and mindfulness is kind of a meditation technique to be always aware of what your state of mind is. And that could be very helpful if you find yourself being stressed about different things. Being aware of what's stressing you or why you are stressed can help you avoid and manage these types of stressors. So in summary, I think stress is a serious health problem, especially when it's in high levels. We are surrounded by stressors all the time. Our really best way to deal with it is to work on our stress response and to avoid, if possible, stressors that we know can be avoided in our day-to-day. And I will stop here and take questions.
Dr. Hajjar, how does stress manifest itself in brain function and dementia?
So for one is, so there's stress in dementia can be affecting both the patient and their caregivers. So there's high level of caregiver stress, especially when the person is impaired. So that element, it manifests itself by the caregiver having stress-related diseases. So they will either have more health problems or just sleeping problems, depression, anxiety, all of these. So that's one way stress can manifest itself in the dementia world or in the dementia patient. The other thing is definitely stress can, as I mentioned before, affect attention and memory. So, and we know that, I know that from myself, and I'm sure other people do, is that when you're stressed, you're less able to focus and achieve tasks. So you're kind of more inattentive. And if you start off with having a lot of memory problems or some memory problems, and now you're adding a stress on top of that, you're going to have, one can have more memory difficulties. So definitely it is a two-way effect. Dementia itself can make people stressed because they're forgetful and they don't know where, are not able to process all the information around them. It causes stress to the caregiver, but also stress itself can make our memory weaker.
Is that related to the high blood pressure? Your studies with high blood pressure and memory?
Yeah, so absolutely. So there is definitely a relationship between the level of stress and the cardiovascular system. And that's pretty much where a lot of the work has been done in the stress world before, is that the exposure to stress, especially chronic exposure to stress, can cause some significant cardiovascular effects. So elevated blood pressure, increase in heart rate, thickening of the heart muscle. And that by itself can affect the brain by causing memory, by leading to memory problems. So it is possible that that's the case. We did identify in the past that people who are exposed to stress have more difficulty controlling their blood pressure, even when they are taking the same level of medication. So it's the relationship between stress and cardiovascular disease and hypertension is important in the brain health, just as it's important in the cardiovascular health.
Dr. Hajjar, there was another question asking whether you can compare how stress differs between people. That is, the same problem is easily taken in stride by one person while it is really stressful to another.
Absolutely. So that's a very good question. This goes to the concept of resiliency or a stress response. In other words, if you take two individuals and you expose them to the same level of stress, one person might have a significant elevation in blood pressure, significant elevation in their autonomic nervous system, so the flight and fight reaction. And another person might not have the same response, and it would have less increase in blood pressure and may not be even stressful at all. And the interaction between the stress stimulus, which is the stressful event, and the stress response, really what leads to how health is related to stress. So as I said in the past, previously, if you can't avoid the stress, working on your stress response might be helpful, and over time you might be able to tolerate stressful things that you were not able to tolerate earlier.
Okay, thank you, Dr. Hajjar. At this time, we'll get to our last and final presenter, Dr. Laurence Sperling. Dr. Sperling had to make some rounds, so he couldn't directly interact right this moment. So he did tape his presentation for us. So Ms. Jorbin will get that up for you. And he's going to talk about how heart disease and cardiovascular disease affect older adults, or the effects of hypertension, et cetera, in older adults.
Okay. And Dr. Parker, will you continue? I'm going to have to close out a couple of links.
Okay. Is it going to play?
Just a second. I've got to close out your presentation.
Please bear with us. Do a little bit better about your own health and safeguard your own health and your heart, therefore your brain. Dr. Sperling.
Thank you very much for the introduction, Dr. Parker, and also for the opportunity to share with your attendees today during Men's Health Week. I'm going to speak about the importance of focusing on men's cardiovascular health, and not just during Men's Health Week. We really need to focus on health promotion and disease prevention every day, not just for men, but for women and for families and communities. Because as I will point out, this is of critical importance. I just want to let you know I have no disclosures and no conflicts related to this presentation. The comments are mine and not related to specifically the organizations I work for, work with, or serve. Well, let's think back to the dedication of the National Institutes of Health. This was now 80 years ago. And by the way, it is called the National Institutes of Health and not the National Institutes of Disease. Franklin Delano Roosevelt said at this dedication, we cannot be a strong nation unless we are a healthy nation. This next slide here, the figure is from a paper we published a number of years ago. And this figure demonstrates what is called the health disease continuum. Our slide. There we go. So this is the health disease continuum. And if you look out here in red, this is disease that we often find late in its manifestations. And we certainly can care for individuals with diseases like heart problems, atherosclerosis, heart attacks, and strokes. But it's really important for us to focus here, which is those who are healthy and better understand what it takes to focus on health promotion and disease prevention. There we go. This next slide, I think, is one that I want all of the attendees to really get active in. And this is the American Heart Association's what's called cardiovascular health metrics. And by looking at these 7 metrics, you can calculate for yourself what's called your Life's Simple 7 score. And it's very simple to calculate. These metrics define cardiovascular health and not cardiovascular disease. So there are metrics related to cardiovascular risk factors, smoking, cholesterol, blood pressure, and blood glucose, and also metrics related to lifestyle and behavioral approaches like a healthy dietary pattern, regular moderate physical activity, and an ideal body weight. This table helps you think about, for each of these categories, whether you have poor cardiovascular health, intermediate cardiovascular health, or optimal cardiovascular health. Data that we have from my colleagues at the Center for Disease Control and Prevention through a behavioral risk factor and surveillance survey in over 350,000 Americans by self-report tells us that only 3% of Americans have ideal cardiovascular health. About 10% of Americans have poor cardiovascular health. And we know there are large disparities by age, gender, education, and ethnicity. This is a figure from our National Vital Statistics Report in 2015. And you can see at the top of why men die in our country, cardiovascular disease or heart disease, certainly an outlier. Now, I know this webinar is sponsored by the Alzheimer's Brain Center at Emory, and we know there are many other chronic diseases that are causing deaths in American men. But if we look at Alzheimer's disease plus the deaths from prostate cancer, these deaths combined equal the deaths caused by the number 5 cause of deaths in men, which is stroke. The center that is hosting this webinar, I know they focus on brain health. And this is a paper that was published just a month ago that really ties together that heart health is brain health. Essentially, vascular health is heart health, brain health, and really translates to cancer health as well, or cancer preventive efforts. In this paper, the investigators looked at 1,600 individuals who are already at the age of 80 and followed them out for 20 years. None of these individuals had dementia, and they did a yearly evaluation of brain health, essentially, looking at their thinking, cognition, memory, working memory, and then also the speed of perceptual recall. And here in blue, those who had the lowest heart risk scores tended to do the best over 20 years in this already older population in all of these metrics. As a cardiologist and as a preventive cardiologist, we often think about traditional cardiovascular risk factors: high blood pressure, cholesterol abnormalities, diabetes, smoking, obesity, poor diet, and physical inactivity. Well, these traditional risk factors explain part of, but not all of, cardiovascular risk and vascular risk. This is from a paper we published a few years ago, and it points out that our socioeconomic status is a great predictor of our risk for disease and also a predictor of our health. And we need to think very differently as we approach addressing traditional cardiovascular risk factors versus socio-demographic factors like poor access to care, healthy food, psychosocial, behavioral, and environmental factors, because our interventions are quite different. Here, more focusing on behavior, community, education, and then at the level of policy. Well, this is Men's Health Week, and as I mentioned, we need to focus on the health of men and cardiovascular prevention, not just this week, but every day, because men are less likely to seek medical care. They're half as likely as women to go to the doctor. They're 3 times as likely to go 5 years without a doctor's visit, and they're twice as likely to never have contact with a health professional. Luckily, men that have a partner and social support, for instance, married men or men that are part of a family that's supportive, tend to have a better chance of receiving and following up with regular medical care. So I do think the future of cardiovascular medicine, it has to be a greater focus on cardiovascular health and prevention. Since October of 2019, I've had the honor of serving as the executive director of a national initiative called the Million Hearts Initiative. This initiative is shared by the Centers for Disease Control and Prevention and the Center for Medicaid and Medicare Services. It was started in 2012. The ambitious goal of Million Hearts is to prevent at least 1 million heart attacks, strokes, and cardiovascular events among Americans. The 3 pillars of Million Hearts are keeping people healthy by reducing sodium intake, tobacco use, and increasing physical activity. This is more at a population level, although we should do this as individuals. Realizing at a population level, this is really getting down to where we live, work, play, and learn. Million Hearts focuses on optimizing care. This is focusing on the ABCs, appropriate aspirin use, blood pressure control, cholesterol management, and smoking cessation among those with heart disease and those with risk, increasing utilization of cardiac rehab, focusing on heart healthy behaviors, and improving outcomes for priority populations. Our 4 priority populations, although there are many priority populations that we focus on, are African Americans with hypertension, the 35 to 64-year-old age group, because in this age group, we see a really disturbing increase in cardiovascular events over the past decade. 2/3 of the counties in the United States in this younger age group have increasing heart disease and stroke rates and mortality. We focus on those who've already had a heart attack and stroke, and those who have mental and substance use disorders. Again, I thank you for the opportunity to speak to those on the webinar today attending this important Men's Health Week session. And I'd be absolutely glad to address any questions or comments.
Thank you, Dr. Sperling. There are some questions in the chat. One of the things that you spoke about was that poor people have regular risk factors like high blood pressure, diabetes, and other things for heart disease, but you talked about lower socioeconomic and educational status. So for people in that category, are you saying that in addition to medications, we have to do something else to help these people?
You know, most definitely. We often conceptualize that health and disease are determined by our health systems, our healthcare systems, and really only about 20% or so of health and disease are determined by traditional healthcare systems. And so really health happens out there. Out there is where we live, where we're born, where we live, where we work, our communities. It's where we learn and play and pray. And so there are significant disparities in health and risk for disease in our country. And these are disparities that right now in the setting of a pandemic, we are learning that these disparities are playing out and we have vulnerable populations where we have to recognize that we need to invest in health across the populations to create equity at the level of policy, support, and a lot of the support is at the level of the community, interfacing between health systems, our community, and public health.
How can, you talked about the organization Million Hearts, somewhat familiar with it, but can anybody who's on this webinar become part of Million Hearts? Is that something we can be part of? And what does it exactly do?
Sure. So Million Hearts was started in 2012, and it's explicitly a partnership between the CDC and the Center for Medicaid Medicare Services. This is a national program. Million Hearts has have over several hundred partners across the country. These are organizational partners. We work across all 50 states and territories of the U.S. As an example, this week we had a meeting with the National Association of Community Health Centers. There are 1,400 community health centers in the U.S. that help serve 24 million Americans in terms of health, promotion of health, and disease treatment. And so our network is across the country. As an individual, I think it's important you realize that there is this Million Hearts initiative. I want all Americans to be aware that there are millions of hearts at risk, and that we can't wait until an event occurs to take our heart health seriously, that each and every one of us needs to understand our risk, focus on doing something to improve our risk, understanding our family history, and partnering and becoming a part of our care with our care team through shared decision making. Heart Month in February was focused on hypertension control in African Americans at the CDC. Our push and our slogan was, "Together we've got this," which means heart risk factors are identifiable and they're treatable, and the majority of heart problems, risk for heart attack and stroke, that's preventable.
Okay, I agree with all of that. What are the ABCs? And if it's at all possible, can you pull up that risk factor slide with the body mass index and other things that people needed to be aware of? Like that checklist for am I at high risk or low risk for heart disease?
Absolutely. So first I'll talk about the ABCs. As far as pulling my slide back up, I mean, if I can have the slide deck back up, I can dial back to that slide, but I think I've got it in my brain anyway. As far as the ABCs, this is just a construct related to the medical and public health term would be called population attributable risk. And so we know by making modest changes in risk factors that can be treated through evidence-based proven therapies across the population, we can prevent thousands, hundreds of thousands, and million cardiovascular events. The ABCs stand for appropriate aspirin use, definitely in people with known cardiovascular disease. For those who are in primary prevention, there we have to really call into question the risks of aspirin versus the benefits. And this should be something to talk to your clinical team about. Blood pressure control. Blood pressure control in our country has been flat over the last 10 years, really at about 50% or so. And we know many people are aware they have high blood pressure. They're under treatment, but their blood pressure is not being optimally controlled. The C is for cholesterol management, and we know there are low-cost medications available in addition to following a healthy dietary pattern that can not only lower cholesterol levels, but significantly affect heart risk. And S is for smoking cessation. despite our country making some really great strides in tobacco use and also in secondary tobacco exposure, about 18% of Americans, still 15 to 18%, depends on the population, still smoke. And just maybe 2 months ago now, the Surgeon General's report on tobacco cessation was released. This was the first Surgeon General's report specifically on tobacco cessation in over a decade, maybe several decades. And so we know at every stage of life, quitting smoking has significant benefits related to the reduction for heart attack and stroke.
And this is going to be the last one about daily aspirin. You said appropriate aspirin use, okay? So people who have angina, congestive heart failure, there are probably people who need to take aspirin. But what about people who are somewhere between 50 and 75 and they're healthy, they don't have high blood pressure? Should they be taking an aspirin every day?
Yeah, so first just to answer the second part of your prior question, the traditional heart risk factors that you should be aware of are high blood pressure, high cholesterol or abnormal cholesterol, smoking, diabetes, obesity, physical inactivity, and an unhealthy dietary pattern, as well as your genetic risk. To answer the question about aspirin, this is a complicated answer. For each individual, you want to know your risk. And unless you're a very high-risk individual, in general, aspirin for primary prevention has a higher risk of a side effect than a benefit. The medical term we use is net clinical benefit, and that's the potential benefits versus the potential side effects or risks. So here I would say talk to your physician or clinical team, raise the question. There are still people who are primary prevention patients who are high risk, who have a low risk of bleeding, where the benefits of aspirin outweigh the risks. But I think using aspirin every day to protect your heart comes with the risk of bleeding.
Thank you very much, Dr. Sperling, and thank you so much for taking the time to be with us today. And we look forward to hearing more from you. And I guess we're going to get some more information about Million Hearts and the CDC's initiative on heart health with CMS. Thank you.
Thank you very much. And again, thank you for the opportunity.
Okay, I think that concludes the formal presentation. If there are any more questions, please send them in the chat. We are going to be able to answer some questions in the Q&A in the chat session. Ms. Dorbin, any more?
There was a question about accessing the Million Hearts. So I will, when we send out the recording, I'll send out the PDF and the link on how to access the Million Hearts program.
Okay. I see no more questions. So thank you all for joining us. Please tune in again next week, next Wednesday, when we're going to have a panel discussion featuring Dr. David Satcher, Dr. Ambassador Andrew Young, Dr. Alan Levy, Dr. James Law, and Dr. Clinton Dye, as well as Ms. Patrice Harris, outgoing president of the AMA. Thank you.